Yes, ma'am. Visible objectives.
All right. Okay. So, screen sharing. So, what is the definition of the screening test? And what is the reason? Well, we do screening to screen out those people in a population who can be at risk of developing certain disease, or they have certain risk factors, and we want to find out that well, out of all those healthy people, what is the number of people who are at risk of certain disease or developing certain problems in the future, or and diagnostic tests are those we do it when once we screen a population, say for example there is one whole community, and we want to screen that community for any like some infection or something of that sort, and we do the test of all the community, the whole 400 500 people living in that area. And out of those people, if 5 10 20 people who turn out to be screen positive, that is, there is a suspicion of that they have got this certain disease in them, then we do certain further testing on them to finally make a diagnosis that whether this disease is actually really present in them or not. So the diagnostic tests are always applied once you have screened that population and you have picked out the high-risk people from that population, and then you make a diagnostic test, do a diagnostic test to confirm your final diagnosis. Right? So the diagnostic tests are usually always performed on those people who turn out to be positive in their screening tests. So this is sort of a chart giving you the whole comparison between the screening and the diagnostic test. That is, we want to, in screening, we want to just detect the potential disease, whether it is present or not in that particular area. And then when that screening test comes out to be a positive, we do a diagnostic test to find out, well, to make it a 100% diagnosis that yes, these people have the problem. Well, target population is what? Asymptomatic people, like what is happening these days. If you take a certain community, certain area, and you start screening for this COVID-19, out of those, all those people who are there, they are all at risk of having a COVID-19, but everybody doesn't have it properly. So you screen them and you pick out those positive screened COVID positives, and then you do a PCR test on them to finally confirm whether they are really affected by this COVID-19. So you large asymptomatic people who are at risk are screened, and those either symptomatic people or those screening positive people, then they are put to undergo a diagnostic test. Testing method simple. Always screening methods are always simple, non-invasive, easy to perform, cheap, not very expensive, and easily acceptable, especially to the people on which they are being performed. But diagnostic tests are always, most of the time, they're quite expensive. They are they may be invasive tests, and but we need to perform it to confirm our final diagnosis. So in the screening test, the sensitivity of that screening test, that needs to be very, very strong in order to pick up all those individuals who are at risk of developing that disease. But as far as the diagnostic tests are concerned, because we perform it on the screen positive test, the diagnostic test needs to be very, very specific, and they should have a high specificity to pick up those positive final positive test people. Again, I said it should be cheap, but these are expensive tests to perform diagnostic tests. So as far as the gynecologists are concerned, why do we are more concerned with the doing a prenatal screening test on certain individual group of females to identify all those fetuses who are at risk of developing certain disorders. For example, the family is a carrier of certain genetic problem. We do it. Any structural problem, we do it. Family has some metabolic syndromes going on, certain hematological problems. In Pakistan, we see thalassemia a lot. So those families who are at high risk of developing thalassemia because they are carrying a trait of thalassemia, the mother is carrying a trait of thalassemia, maybe the father is also carrying the trait of thalassemia. So we need to screen out that couple, that the baby they are carrying is what is the condition of that baby. And once you do a screening test, and then all those, again, as I said, those who test out to be positive. Similarly, we screen those people who are at risk of developing diabetes, gestational diabetes in pregnancy, because if they have a history of diabetes in the family or other risk factors, they are at high risk of having developing gestational diabetes in this pregnancy. And if it goes unidentified, then it has its implication on the pregnancy further on. What, as I said, what would be the advantages of this screening test? Because once you do a screening test, you mark out a population, then it becomes, there are certain abnormalities, certain chromosomal problems, certain structural problems in the fetus, which are incompatible with that. So if that is picked up, that from that screening test and the diagnosis is confirmed, then you can offer a termination of pregnancy to that couple. And this will help in reducing the perinatal mortality, because if that pregnancy goes up to the term and the baby is born, the baby won't be able to survive in postnatal life, and that will result in the death of the baby. So that helps in, if you diagnose it early, you terminate the pregnancy early in the first, second trimester, so that reduces the mortality, perinatal mortality rate. Then again, if the baby has got some structural problem, which is not that severe, like for example, a cleft palate hai, or a cleft lip hai, or baby is developing a hydrocaph and all that, or the baby has some deficient these digits, or the baby has achondroplasia and all that. So once you diagnose, and you are able to counsel the family, the couple, that look, this is the problem with the baby. The baby will be born with these problems. The baby would be a short-heighted one if he or she's got achondroplasia, or the baby has got cleft palate. So that the couple is mentally prepared. They know that yes, a baby is coming who has got so and so problems with it. It's not going to be a surprise. What, this has happened? You did not tell us. We didn't know. The doctor didn't know, and suddenly the baby is born like that. So this is all. And therefore, for the psychological, well-being of the parents, it's essential that if we had screened the patient, if we had made the diagnosis, we are able to tell them clearly, okay, look, this is what the baby is going to be like, and so that they are mentally prepared. They can go about, find out about more, read it, increase upon their knowledge about the particular disease and whatever. And if there is any in utero treatment available to that particular problem with the baby is carrying, that can be prescribed to the couple at that point in time. Then again, certain chromosomal diseases, if we identify them during the screening process, then we can apply, we can give them an option of going through a diagnostic procedure to finally confirm their diagnosis. And like chromosomal diseases, like chromosome 21, 18, 13. These are the ones which can be then undergo a diagnostic test to be confirmed. So, what are the different methods of screening and diagnosis? For the screening, we have got biochemical method, that is we do blood testing, maternal blood testing. Then we have ultrasound scan to pick up the congenital malformations in the developing fetus. And then for diagnostic purposes, we have certain invasive diagnostic tests like chorionic blood sampling, like amniocentesis, and like fetal blood sampling to further confirm the diagnosis. So, how do the biochemical tests are performed, and what are the biochemical tests which are available? So, there are a couple of hormones which are being produced, which there are certain levels at certain particular gestation that can help us in picking up the abnormality. So there is a hormone which is produced, alpha fetoprotein. It is produced by the liver of the fetus, and it then enters into the maternal circulation, and from there we take the blood, mother's blood, and we test on it. How do we do it, and at what stage we do it? In the next slide I will explain. Then we have human chorionic gonadotropin, then we have estriol, then we have inhibin, and then we have this pregnancy PAP-A, which is pregnancy-associated plasma protein A. Now, one of the common defects which are seen in the fetus is the neural tube defects. Now, neural tube defect can be in the form of a hydrocaph, that the baby has got excessive amount of fluid in the brain, and the ventricles are dilated, or there is a abnormality in the vertebral column of the baby. There is a spina bifida with the meningoceles and meningomyelocele and all that. So it can present in any form. Now, for screening of and then neural tube defects, anencephalics PR, in which there is the bone, skull bone, this part of the bone that is missing, and the baby's brain that is exposed to the amniotic fluid. So this alpha fetoprotein that is produced, as I said earlier, by the fetal liver, and then it crosses into the maternal blood. And it starts rising from 12 weeks of gestation, and maximum rise to it is up to 32 weeks. We at the when it should be measured in the pregnancies, it's around 18 to 20 weeks of pregnancy, right? So what happens is that for that we should know the exact gestation of the fetus. What is the LMP? What is the ultrasound says that what is the gestation of the fetus, so that we do it at that particular point, and we measure that amount, and we express it into the multiple of medians. And 2.5 is the cutoff of the level which is taken. Anything beyond 2.5 at that particular gestation is considered abnormal. The majority of the neural tube defects, they can be detected by doing an alpha fetoprotein of the in the maternal blood, it's a highly sensitive test, and the false positive rates are very, very low. But since we have now have very good ultrasounds, and which have got very, very good resolutions, so now the anencephalics and the other neural tube defects like spina bifida and all those hydrographs and dilatation of ventricles, whatever, they are all easily diagnosed by ultrasound. So we need not do this maternal alpha fetoprotein. But before, if we are doing it in the blood, so we need sorry, I'm so sorry. So
आपकी आवाज में थोड़ा सा इको आ रहा है.
What we do is that बेहतर हो गया?
मैम थोड़ा सा
So
इको
there
आ रहा है
are
आपकी
certain
आवाज
other हाँ, अब क्या करूं फिर? What should
हाँ
I
मैम
do?
मैम माइक आपका लैपटॉप जो है वो थोड़ा सा अगर पॉसिबल थोड़ा सा बस करीब कर लीजिए मैम।
I'm very close to my mic laptop.
ओके मैम मैम आप कंटिन्यू कर सकते हैं। ओके
अच्छा। So there are other conditions as well which need to be excluded before we are doing this thing, alpha fetoprotein for neural tubes, like multiple pregnancy, any abdominal defect in the fetus, or any congenital nephrosis and kidney problem in the fetus. Now the conditions in which it is lowered is Down syndromes and Edwards syndrome, insulin dependent diabetes, overestimated gestation definitely, and the high BMI of the mother. So as I said, till now we don't do it. Now another important condition in which we do prenatal screening, and that is Down syndrome, that is trisomy 21. Because trisomy 21, it affects lots of females, and it has got a direct relationship with the maternal age, as the age of that also increases. And since and this presentation of this Down syndrome is very variable. Some babies are not very much affected, but there are certain babies who are crossly affected by it, and they present with multiple congenital cardiac problems, respiratory problems. They have, their mental age is way behind the chronological age, and obviously because of all these difficulties, it becomes very difficult to bring up such children, and they need special care and special schools and special teaching materials and whatever to bring them up in this bring them up. So the hormones which we test is the alpha fetoprotein, hemochronionic gonadotropins, inhibins, estriol, and papain are tested. And there are different gestations at which they can be tested. First trimester testing done, or if the woman presents late in the pregnancy, then the second trimester testing is done. So if she comes in the first trimester, what we do is that this beta HCG levels in the maternal blood and the papain level in the maternal blood, along with the maternal age. There's a computer program. You feed into all these values, and this computer will, calculate the risk, and that will present to you, and then you can come recording. If in this these two tests, if you add in the knuckle translucency, what we do is these days that in the first trimester, the woman comes, we do a beta HCG, we do alpha fetoprotein, we do inhibin, papain, and do a knuckle translucency, and then you put it in. So you see the detection rate, it gradually increases. The more screening criteria test you put in the single test, the detection rate of the disease that increases in that person. As I said, if the mother comes late in the second trimester, so either we do a triple test, this one, or we do a quadruple test on her. And then again, it's the computer which calculates the risk and gives you the result of it. Now, once these tests are done, obviously before you are doing a test, one has to have an exact gestational age, calculated gestational age. Then we should make sure that she's not carrying twins, because if she's carrying twins, obviously the number of hormones which are being used are twice. So that test would again change, and she doesn't have any other problems that affects the test, and then you do it. So what happens? This is the test. This is the values which you get. Papain comes out to be low. Beta HCG is very high for that particular period of gestation. So is the estriol, which is low, and alpha fetoprotein, that is low. The RCOG guidelines and the American College of Obstetrics and Gynae guidelines, they all suggest, rather in UK, if you go, any female beyond 30 years of age, whether she is high risk for Down syndrome has any high risk factors in her, like had a sibling with a Down syndrome or had a previous baby with a Down syndrome or something of that sort. They are all screened for it. And at that point in time, in the early pregnancy, they are offered a nuchal translucency, their BDCG, and that they are done between 11 weeks and 13 weeks, 6 days. And that is, and those who come late, between 15 second trimester, they are done. They are offered a quadruple test for screening out for the Down syndrome. Now, the other chromosomal abnormalities which can be detected by these biochemical tests are the trisomy 18, 13, because these are the ones which, although they survive the pregnancy, but they don't survive outside the, once they are delivered. So we do a test and we counsel the patient accordingly once we are done with it. The Turner syndrome, triplety, which are inconsistent with the survivors. So these are the biochemical tests which can help us in detecting the screening of the females who are at high risk of developing second. Now, the second technique by which we screen the patients, and if you have been attending the gynae obstetric outpatient clinics, you've seen that between 18 to 22 weeks, we always prescribe an anomaly scan to the pregnant females to check for the major structural abnormalities in them. And some of the soft markers for the chromosomal abnormalities, they are also looked at. But again, for that, obviously, we need a good ultrasound, we need a good sonologist who can pick up all these abnormalities. And then, obviously, the fetus is grossly has got a number of multiple anomalies going on, which are not going to be compatible with that, and accordingly, the patient is counseled for that. So, who are to be screened for these congenital anomalies? All those females which would have got certain risk factors like known diabetics with uncontrolled diabetes and they enter into pregnancy. They have got higher risk of having a baby who is congenitally malformed, hydrogaphobia, Portal syndrome or so. Those who are epileptic and they are on anticonvulsants, because anticonvulsants, they have directly affect the development of the embryo and the especially patient on the warfarin. But majority of the female, you don't find everybody on anticonvulsant or everybody who's diabetic, or there's a normal couple who have had a couple of normal pregnancies, suddenly they have one baby who is congenitally malformed. So quite a high percentage of abnormalities, they occur in people who have got no risk factors for that, or no reason for developing a defect. So what, as I said, between 18 to 22 weeks, you do it, and what do you check for? Number one is the viability, then the number of fetuses, amount of fluid, and the location of the placenta. Then this is the journal thing which is done. Then for when you are started screening for doing a anomaly scan, you start that step approach. You start doing it from the top to the bottom. Head pelvis up, fetus scan. You look for any structural abnormalities, bony structure. Then the brain matter inside. Look for that, the ventricles and all that. And then you come down to the face and you look for the nose, developing the nose, and look for the cleft palate, cleft lip. Down below into the chest. In the chest, you look for the position of the heart, the lungs, and then look for the 4 chambers of the heart. And then in the abdomen of the kidneys, the stomach bubble, that is very important. If somebody, a baby has a during literature, that fetus will have good bubbles, double bubble sign कहलाता है वो. एक stomach का bubble नजर आएगा, आगे duodenum चूंकि block हुआ है तो जैसे duodenum जो है ना वो खुला हुआ है, तो the two bubbles are visible in that. Then you look for the whether it is filled or not. Then you down and you screen all the 4 limbs of the fetus to see the size of the according to appropriate for the gestation, the number of bones, the digits in the hand, and everything. So that's how the ultrasound screening for the structural abnormalities is carried out. Now, once you have done, and there are certain, if you have picked up or not, you do, there is certain diagnostic tests which are available, and the amniocentesis, chorionic villus sampling, and fetal blood sampling. These are the diagnostic tests. You take out the fetal cells directly, and you do a chromosomal analysis, and then you pick. Now, the advantages of these is that they give you they are very sensitive and specific tests, and they pick up the abnormality which has been presented. When do we perform amniocentesis? Around 15 to 16 weeks of gestation. This happens when the baby's woman is coming late in the trimester, and we suspect that she has has this problem, her family history, or she's high risk or whatever. Then we do it. So we do a fetal karyotyping if you want to, because there are certain conditions which are recessive, dominant recessive genes, dominant genes which are passed on from parents to the baby. So we first of all we try to find out what is the karyotype of the fetus which he is carrying, and then we test them for Down syndrome. If the ultrasound has got some soft markers like echogenic focus in the heart or in the intestine, then we do a test for other chromosomal abnormalities, 18 or 13, or which can be, or the parents, they have balance dislocation of the chromosomes, or they have a previous history of chromosomal abnormality, fetus. So these are the people who need to be screened for. What we do is that we take the fluid, we extract the fetal cells from it, and we develop do it under a fluorescent technique, and we do either a PCR test or we do this FISH test on it, and that gives us a result within 24 to 48 hours, and then we can again counsel patient accordingly. There is not a long wait to get the result, and uncertainty happening around it. So this is how this thing is done for your amniocentesis. You see, you first do ultrasound and you locate the placenta, because you don't want to go through the placenta, and then you find the deepest pool of amniotic fluid, and through that a long needle is inserted through the maternal abdomen, pass through the uterus into that amniotic fluid pocket, and a few cc's of fluid is extracted. Excuse me. The second technique is the chorionic villus sampling or placental biopsy. That is, it can be performed as early as 10 weeks of gestation. And again, we have got two approaches. Either we go through the abdomen or we go through the vagina, transcervical. Transcervical approach is done when the placenta, the developing placenta is in the posterior part of the uterus. So we can't approach it through the abdominal route, we approach it through the transcervical route. And again, we can do it very early in the gestation. We don't have to wait for the second trimester to do amniocentesis. We take it out and we check it under PCR and FISH, and we do the test and we give the results as early as possible. And the counseling of parents is done with the geneticist. Appointment is given, neonatologist sits with them, and the pros and cons of all the things are discussed, and then the decision is left to the parents to decide. Fetal loss rate is about 1% in both the cases. It was at time it was prescribed. It was said that maybe if you do it at early, it can result in some fetal defects in the fetuses down there, but that is not been proved. This is how it is done. Again, same technique. Ultrasound से आप placenta develop जहाँ हो रहा होता है उसको locate करते हैं. देखिए, this is the placenta which is developing here. You go through with a long needle, spinal needle होती है, through you pass through it and you go inside and you take suck it fluid and the villi and you come out and then that is done. Now, fetal blood sampling is again a technique, but it is done later in the gestation when the fetal hemopoietic system is completely developed and there is blood circulating. And this, from where do we take the blood? We take it from the umbilical cord, at close to its insertion to the placenta. Now, this is usually performed in those cases like we are suspecting RH incompatibility is there and the fetus is developing anemia and we want to see the type of hemoglobin levels of that fetus, or we or baby has this thing maternal thrombocytopenia which is affecting. So usually it is performed for the hematological disorders from which the which are suspected to be, with the baby suspected to be suffering. It has its own obviously complications. Fetal loss is about 1 to 2%. Bleeding can occur at the site जहाँ पे आप puncture कर रहे हैं, which can and it can cause which can obviously cause some problem. Then if the mother is HIV positive, it can infect the baby, and if the mother is RH negative, so you are doing a fetal blood sampling, so that can sensitize the mother, because if you don't know the blood group of the baby, so after doing this fetal blood sampling, you need to give an antidote to the mother as well. Now, fetoscopy, this is something very interesting. It is just like a laparoscopy, which is done. You go into the abdomen in a laparoscope and you observe the internal organs, and then you perform operative procedures via laparoscope and all that. So fetoscopy is something same. Here, this is this fetoscope, which is a fiber optic type, flexible. It passes through the maternal abdomen, through the uterus, and directly you visualize the fetus. And you can directly diagnose some congenital structural abnormalities. You can take the biopsy from the skin, from the muscle, if there is certain muscular dystrophies are suspected, and in cases of fluence where there is twin-to-twin transfusion happening and resulting in the problems with one twin, and so you can through this you can via laser आप जो vessels, जो communicating vessels होती हैं, उनको you can coagulate. But these things are not practiced here and not in every center. Specialized centers होते हैं, special trained doctors होते हैं who do it. Now, other conditions which are which require antenatal screening are the screening for the GDM. Now, why do we want to screen for the GDM? It's because being a South Asian population, we have a very high incidence of diabetes in the family, in the people. And the families who are affected with the diabetes, especially if the father has diabetes, then his daughter during pregnancy is at a high risk of developing gestational diabetes. Right? So maternal obesity, if your mother has got a high BMI, she's at a high risk of developing gestational. If somebody has been having big size baby, she's a risk, has this or unexplained intrauterine deaths at term, or people like who have this early miscarriages, repeated miscarriages early. So these are all the people on whom you need to screen them for this gestational diabetes. Now, how do we do it? We do either you do a two-step test, that you do a glucose challenge test and if that turns out to be positive, you go and do a oral glucose tolerance test. But recommended ये कि जो challenge test होते हैं वो, और फिर उसके बाद फिर आप 2 घंटे का glucose tolerance test है, people they find it very difficult to do it, so you go directly and go do a oral glucose tolerance test in all those high risk people who you want to screen. उनको first trimester में जब आपके पास वो first visit पर आते हैं, आप उनको एक OGTT लेकर देते हैं. अगर वो नेगेटिव आ जाता है, नॉर्मल आता है, इट्स ऑलराइट. 26 to 28 वीक्स पे जब प्रेगनेंसी का लोड ज्यादा वजन बढ़ना होता है, उस वक्त आप एक रिपीट करें. अगर वो फिर भी उस वक्त नॉर्मल आ जाता है, तो 32 वीक्स पे जाके उनको आदर ओजीटी ठीक है क्या उनका फास्टिंग ब्लड ग्लूकोज लेवल करा ले, वो आपको गिव यू द रिजल्ट्स. Right? So what are the NICE guidelines? NICE says कि अगर fasting blood glucose level more than 5.6 millimoles हो या 2 hours का आपका 7.8 से ज्यादा हो, person is diagnosed as a GTM. WHO 5.1, 1 hour का 10 और 2 hours का 8.5 कहता है. So आपको इस हिसाब से जो ना उसकी रिपोर्ट को देकर और उसको एडजस्ट करना. अनकंट्रोल्ड अगर पता ही नहीं चला हमें अनकंट्रोल शुगर पे जा रही, क्या हो रहा है, बच्चा बहुत बड़ा होता चला जा रहा है, मैक्रोसोमिक 4-5 किलो के बच्चे पैदा हो. Sudden IUD at term, difficult birth because the baby is big, the shoulders get stuck. Baby needs to be admitted in the ICU because of what? Hypoglycemia, because of neonatal jaundice, because of the hypocalcemia, because of hyperbilirubinemia. इस सारी चीजें बच्चों में होंगी and the बच्चा will be in trouble. Maternal risk क्या होते हैं? Obviously difficult बचाना डिलीवरी, अगर आप पीछे से डिलीवर करा रहे हैं, शोल्डर डिस्टोशिया हो रहा है, टीयर्स आ रहे हैं, जेनिटल ट्रॉमा हो रहा है, सारा कुछ हो रहा है. और अगर नीचे if the baby is so big, you need to do a cesarean section on that person. So these are, and this woman who has gestational diabetes and produces big babies, she in next 10 to 15 years she's at high risk of developing full-blown diabetes. Then we have this RH prophylaxis. Now, you know, this is a very important subject and important topic. When you come in family, there is a whole lecture on it. But हम क्या करते हैं? Antenatal पे, the most important. There are 5-6 blood tests which are given to the woman who comes for the first time to your antenatal booking, and one of them is blood grouping and RH factor. Why it is important? You need to know what is the blood group of the woman and what is the RH group of the woman. RH positive है या RH negative है? Because if she is RH negative, that she has this antigen not present on her blood cell, she is RH negative, and once she is RH negative, we need to know what is the blood group of her partner. Because if her partner is RH positive, which majority of the people are, then she is always at a risk of having babies who are RH positive, who will sensitize her to the RH positive blood cells, and whenever she becomes pregnant with an RH positive fetus, she will result in a hemolysis of the blood of the fetus she's carrying, who is RH positive, resulting in anemia and heart drops and whatever. So we need to know the blood group of this woman, pregnant female, very important. And if she's negative, we need to know the blood group of the male partner, right? What are the factors which can lead to sensitization? If she miscarries the baby, there's a chance a few fetal cells, especially अगर आपने उसकी वो DNA किए, तो वो maternal circulation में चले जाएंगे और cause करेंगे sensitization. अगर pregnancy terminate हुई है because of any reason, if she has antepartum hemorrhage, especially a rupture of placenta, if there has been a prenatal testing going on, chorionic sampling हुई है, या amniocentesis हुआ है, या fetal blood sampling हुई है, सारे factors हैं जो उसको sensitize करते हैं. So we need to know that. So how do we prevent it? We give an intramuscular injection of NTD within 72 hours, right? Females who are RH negative, if they produce an RH positive fetus, लेकिन अगर कोई sensitizing event हो गया हुआ है, miscarriage हो गया, abruption हो गई, IUD baby deliver हो गया, आपको नहीं पता, या ectopic pregnancy हो गई, आपको नहीं पता कि वो blood group क्या था उस बच्चे का जो ये pregnancy जो lost हुई है. So in that case, आपको हर खातून को NTD लगाना है. हर प्राइमरी ग्रेविड पेशेंट को जिसने पहले कोई इसका सेंसिटाइजिंग नहीं हुआ 28 वीक्स ऑफ जेस्टेशन पे एंड 34 वीक्स ऑफ जेस्टेशन पे आपने उसको इंजेक्शन देना है एंटीटी का एंड वंस द बेबी इज बोर्न अगर वो RH पॉजिटिव आता है गिव अनदर इंजेक्शन एंड इन एवरी सब्सिक्वेंट प्रेगनेंसी व्हेनेवर शी इज प्रेग्नेंट और शी लूजेस अ बेबी और व्हाटएवर आप उसको एक एंटीटी का इंजेक्शन जरूर लगाएंगे ड्यूरिंग हर एंटीनेटल पीरियड. Then we have another infection going on, which is a group B streptococcus infection. Screening इसकी important इसलिए है कि ये उस वक्त मदर को कुछ इफेक्ट नहीं कर रहा होता, लेकिन बेबी जो न्यूबॉर्न बेबी पैदा होता है अगर मदर ग्रुप बी इन्फेक्शन के लिए पॉजिटिव आई है इन दैट प्रेगनेंसी क्लोज टू trimester, later trimester, last trimester, so the baby will have neonatal sepsis. This is important. So हम क्या करते हैं, ये कब ट्रांसमिट होता है, जब मेम्ब्रेन्स में amniotic bag की रप्चर होती हैं until the time of delivery. This is the time period when it is transferred from the vagina into the fetus. So it is suggested, recommend ये किया जाता है, अमेरिकन बॉडी जो है वो रिकमेंड ये करती है कि आप 37-38 वीक्स पे हर औरत का हाई वेजाइनल स्वैब लेके ग्रुप बी के लिए उसको स्क्रीन कर लें. लेकिन यूके की जो RCOG है वो ये रिकमेंड नहीं करती कि आप हर एक को करें. वो कहती है अगर कोई सिम्टोमेटिक है तो करें. यूनिवर्सल स्क्रीनिंग इज डन. यूके में कोई स्क्रीनिंग नहीं की जाती, पाकिस्तान में तो अल्लाह हाफ़िज़. नाउ रिस्क फैक्टर व्हाट आर द रिस्क. अब आपने क्या करना है, हमने क्या करना है, एक खातून हमारे पास आ गई है, लेबर में है, अगर उसको इंट्रापार्टम फीवर चल रहा है मोर देन 60 या उसकी मेम्ब्रेन्स को रप्चर हुए हुए मोर देन 18 आवर्स हो, या प्रीमेच्योरली बच्चा पैदा हो रहा है एंड द मेम्ब्रेन्स हैव बीन रप्चर्ड, या उस खातून का प्रीवियस कोई बच्चा GBS के साथ था, उसकी हिस्ट्री है, या उसको इस प्रेगनेंसी के अंदर उसको UTI हुआ, आपने यूरिन टेस्ट किया और उसका जो कल्चर एंड सेंसिटिविटी है उसके अंदर ग्रुप बी पॉजिटिव आ गई, तो आपने उस खातून को जरूर एंटीबायोटिक देना है जिस वक्त वो डिलीवरी के लिए आए. Usually they have no symptoms. Affected babies क्या होता है, sepsis like symptoms होते हैं. ठीक बच्चा आपने दिया, ठीक ठाक एडवांस स्कोर के साथ बच्चा पैदा हुआ है, मगर within 24 hours जो है ना कोलैप्स कर गया, टैकीकार्डिया हो गया, बच्चा दूध नहीं पी रहा, बच्चा रो रहा है, उसको फीवर हो गया. अब आपने जो ना मुश्किल में फंस गए सारे टेस्टिंग हो रहा है, पता चला कि जी ग्रुप बी आ. So हमने how do we manage such people? Antenatally, if detected, no treatment is recommended and it does not reduce infant's infection. एंटीनेटल देने में कोई फायदा नहीं होता, सिर्फ इंट्रापार्टम एंटीबायोटिक प्रोफिलैक्सिस देनी है. ठीक है, आपने डिटेक्ट कर लिया, आपने उसके यूरिन में बैक्टीरिया आ गया या उसका हाई वेजाइनल स्वैब में GBS आ गया, आप उस एंटीनेटल कार्ड पे बड़ा लिख देंगे कि प्रोफाइल एंड GBS prophylaxis to be given at the time